Good morning. Thank you very much for the invitation. Honored to be here. For the interest of time, I will walk through two cases that touch my topic, which is the in-office procedure for neurotrophic keratitis and recurrent corneal erosion syndrome. So case number one is a case of recurrent corneal erosion syndrome of 59 years old female with complaint of sudden sharp eye pain upon awakening in the morning with tearing, photophobia, and blurred vision. She reported recurrence of the symptoms every 2 and 3 months, and she had a history of the corneal abrasions around 6 months ago. So the treatment started with artificial tears and gel, hypertonic sodium saline, bandage contact lens, and we did anterior puncture for stromal puncture for 5 months that gave her period of recovery for 5 months again, but the condition was recurring back again. So what is the next steps? Next step, either we can go for aggressive treatment like PTK, phototherapeutic keratectomy, or we can have something like in-office amniotic membrane application. So I opted for amniotic membrane application, and as you can see here now, we have the amniotic membrane. We have to do some debridement of the corneal epithelium first by dried weak cell, and then we can apply the amniotic membrane that comes in dried format. Sometimes the amniotic membrane can be cut in a disc with a diameter variable between 9 millimeter diameter or 12 millimeter diameter, and then you can apply the amniotic membrane on the dry corneal surface after debridement of the corneal epithelium. So here just I'm picking up the disc of the amniotic membrane, and here we have 2 marks to identify the epithelium and stromal side should be placed, that this epithelium side should be upside while the stromal side facing the corneal side. And now we are ready to apply this amniotic membrane. The most important thing is to dry the cornea completely again. Make sure that the cornea is extremely dry before applying the amniotic membrane on the dried corneal of the epithelium. And then we can apply bandage contact lens. So it's a simple in-office procedure that you can apply in cases of recurrent corneal erosion syndromes after failure of medical treatment or recurrence of the symptoms and the patient is not satisfied, or the symptoms that affects the quality of life for those patients. So here, what is recurrent corneal erosion syndrome? It's a chronic surface disease characterized by repeated breakdown of the corneal epithelium. It's caused either by trauma, minor trauma, or sometimes dystrophy, and aggravated by corneal epithelial dystrophy. The role of MMP here, the MMP9, it has already ruled here. There is inflammation, or the trauma of the corneal epithelium triggers inflammation, and this inflammation released MMP9 and MP9 and MMP2, and these enzymes that cause degradation of the basement membrane and preventing the formation of the desmosomes and anchoring fibrils of the corneal epithelium. So it prevents stable healing of the corneal epithelium by the inflammation. So here we have the amniotic membrane that is directly can counteract the effect of MMP9 by releasing of the tissue inhibitor metalloproteinase, and this inhibits the MMP9 and MMP2 and promotes epithelial recovery and desmosomes formations. So as you know that other factors for the amniotic membrane in recurrent corneal erosion syndrome, we have of course growth factors that can promote epithelialization and act as a scaffold again for epithelialization and prevent or minimize the pain by acting as scaffold on the affected or denuded corneal surface. The types of amniotic membrane can be freshly prepared or cryopreserved or dehydrated. So of course the dehydrated one is the most intuitive one to be applied in office because it comes in dehydrated format and can be stored in the room temperature. Is different from the cryopreserved amniotic membrane. So this one can be just applied in the room temperature inside the inside the office. So amniotic membrane, again, versus other surgical procedures like the stromal puncture. Stromal puncture is a very effective way for treatment of the recurrent corneal erosion syndrome, but it's somehow aggressive and might promote scarring. And of course, again, amniotic membrane can be compared with a PTK. PTK is highly, again, effective treatment for recurrent corneal erosion syndrome, but it's more intense, more invasive, and more costly. But the amniotic membrane application is very intuitive and can be applied directly in the office with much less cost. So case number 2, it's a case of neurotrophic corneal ulcer, 74-year-old male with mixed infective keratitis, bacterial and viral, not responsible for topical gatifloxacin, hourly encyclopedic eye drops, and vitamin C supplements. The therapeutic treatment changed to fortified eye drops and systemic antivirals. And as you can see, this is the ulcer, and after 3 months, neurotrophic keratitis comes with the neurotrophic keratitis with negative culture, and actually start from neurotrophic keratitis. You know that it's stage 1, 2, or 3. Now it's starting from stage 2 to stage 3. So we have starting rolled in edges of the corneal ulcer, and underlying stromal there is opacification and start of the corneal melting or stromal melting. So here we have to do something for this neurotrophic keratitis. So I started with the in-office amniotic membrane application, and this is 2 weeks after the amniotic membrane application. You can see that there is starting scarring of the cornea, and after 3 months, now the cornea looks much better than before. As you can see, minimal scar, and the patient was satisfied by the actual results because of the healing of the neurotrophic keratitis. So what is neurotrophic keratitis? It's a rare degenerative corneal tissue characterized by damage of the trigeminal nerve, and this leads to partial or complete of the loss of the corneal sensation. And then the cornea loses its ability to protect itself by reflex blinking, and there is loss of the neurotrophic factors that promotes healing after the trigeminal nerve injury. So stages, as you know, stage 1, stage 2, stage 3, and this is the case of stage 2 that was going to progressive to stage 3. And with the amniotic membrane here, we can not only prevent inflammation by MMP9, we have the increase or promote healing of the epithelium by growth factors and neurogenic factors that are already embedded inside the amniotic membrane. So the role of an amniotic membrane in neurotrophic keratitis is act as a physical barrier or a scaffold for the corneal epithelium, and contains growth factors, epidermal growth factors, and as well as neurotrophic growth factors or nerve growth factors that is already lost by the trigeminal nerve affection. And again, it reduces inflammation by counteract the effect of MMP9 and MMP2 and block the interleukins release, and of course prevent melting and scarring of the cornea. So in conclusion, amniotic membrane is a disease-modifying therapy that can be applied in office. It counteracts the MMP9 and provide growth factors together for the epithelium as well as for the nerves. And presence of the dried amniotic membrane that can be stored in room temperature makes the amniotic membrane application in office in some of the resistant corneal ulcers like recurrent corneal erosion syndromes or neurotrophic keratitis is much more intuitive and easy than before. Thank you very much for your attention.